take it away. Hi everyone, my name is MelissaAhrens and I am from Infection Prevention. And so what I'm going to do today is talk to you about our department infection prevention and what that means for all of you. The reason infection prevention is so important is because it's a huge hot topic right now in healthcare, and we like to tell everyone it's in your hands. So real quick, I just like to show that there are 4 people that are in the department currently. We used to have 1 person that covered infection prevention. Now we have 4, again, because it's such a big deal and it is a huge topic in healthcare. So what is a healthcare associated infection? Throughout the presentation, I will refer to a healthcare associated infection as an HAI. So a healthcare associated infection is an infection acquired as a result of or related to care in a hospital or healthcare setting. So that could also include your ambulatory surgery centers, your outpatient clinics, long-term care, etc. How serious are HAIs? HAIs continue to impact many patients, approximately 1 in 20. In the United States, over 99,000 people will die each year from complications of an HAI. So when I'm saying that to you, what I'm saying is patients are coming to a hospital or healthcare setting to get well, and they catch something they didn't have when they came, and they die from it. And that's not okay, because most of them are preventable. HAIs can cause increased pain, suffering, length of stay, financial cost, and morbidity. For example, for a surgical site infection, patients have to stay in the hospital sometimes up to 16 days longer just to treat that infection. Sobering statistics. Our goal here at UTMC is 0 infections. It's a very lofty goal, and everyone has a role here at the hospital. If all of you are have a position where you will be doing patient care, then you will directly be involved with preventing infection. So, what is the best way to prevent the transmission of infections? We all know the answer to this question is cleaning your hands. So there are 2 ways you can accomplish this here at UTMC. You can use soap and water or our alcohol hand sanitizer. We do have alcohol hand sanitizer available outside of and inside of rooms and in the halls, so it's highly available for you to use. The times when we really stress hand hygiene in our inpatient setting is as you enter the room and as you exit the room. So we have a campaign here called Wash In, Wash Out. So what that means is as you're entering the patient's space, you are expected to clean your hands right before you enter, or immediately enter and go to a sink or to a hand hygiene hand sanitizer. So the thought is hands are always clean whenever you're in that patient's space. Now, once you're in the room and you start doing things and touching things, you are expected to repeat that process as you exit. So you can do it in the room, or when you exit out of the room, you can use a sink in the hall or the Purell or the hand sanitizer outside of the door. The other times it's really important, and I would like to stress, are if you're touching a patient. So if you clean your hands, walk into the room, start touching the environment, before you are to touch or give care to the patient, you should be repeating the hand hygiene, okay? Another time that I see often as a problem is before putting on gloves. We care about you cleaning your hands before you put on gloves because 1, gloves can sometimes be slightly porous and they can rip when you're doing things. So if your hands are not clean when they're in the gloves, then it's like dirty hands touching the patient. But also think about when you clean your hands and you grab gloves out of that box. If you're not doing that, all the germs that are on your hands are being deposited into that box when you pull those gloves out. So it's basically like having dirty hands, right? So you have to clean before you put on gloves. And then obviously when you take your gloves off, you would repeat the cleaning. This is called Your Hands Tell the Story. I like to show this slide because it's a direct visual of why hand hygiene matters. So you will see that this study was done in a reputable journal where they had a medical student go into a MRSA colonized patient's room. So when I say colonized, the patient was not actively infected. They did not have any open wounds. They just had MRSA naturally living as part of their natural flora. He did an intact abdominal exam, and he went out and touched an agar plate, which is what you use to grow bacteria. So you see the handprint of the little red cocci, that is Staph aureus that grew on that plate from his hand. Then all they simply had him do was clean with Purell very, very well, let it dry, and he touched another plate and nothing grew. So there are reasons why we tell you to clean your hands. It's long proven that is the #1 way to prevent transmitting infection. So next I'm going to move right into isolation. So we have isolation signs here, obviously, for patients who have infectious reasons. So some points to remember are always follow the precautions, so always read the sign. You do still have to do hand hygiene before you enter and before you put on gloves. Read the sign, so wear what it tells you to wear. Remove attire inside the room immediately prior to leaving, and clean your hands again before you exit. I always like to start with standard precautions, which used to be known as universal precautions. So standard precautions just means that if anything is wet and it's not yours, don't touch it. So what do I mean by that? I mean, if you're dealing with urine or feces or vomit, you should be protecting yourself, right? Just because a patient is not in isolation doesn't mean that you shouldn't still be wearing your protective equipment. I feel we have lost sight of this in healthcare, and we need to get back to the basics of this. So another example, if you walk into the room and a patient is coughing profusely, but they're not technically in an isolation room, you should still wear a mask if you're near them, right? Why wouldn't you protect your face? So again, these are just what standard precautions is stressing. Here is our most common isolation or precaution sign. It's called contact precautions. It is our orange sign, and it is used for organisms that are spread through contact, meaning the environment and the patient are contaminated with an organism. You touch that area, and then you touch other spots, and that is how the organism can be transmitted. This is typically used for all of our multi-drug resistant organisms, such as MRSA, VRE, and there are some newer ones as well in healthcare, ESBL and CRE. Those are also highly resistant organisms. CRE, for example, stands for carbapenemase-resistant Enterobacteriaceae, which is a type of organism. Enterobacteriaceae lives in your GI tract. When you get an infection from it, we want to use carbapenem antibiotics. Well, when those organisms develop resistance to carbapenem antibiotics, they're very, very, very difficult to treat. And 1 in 2 patients will die if CRE is in their blood. And we do have CRE in our hospital. So you won't know when you walk up to these doors what the patient has. You just will know what you need to do to prevent transmission. So for these rooms, you need to wear gowns and gloves upon entering. So you would do hand hygiene, put your gown on, put your gloves on, and enter the room. This sign is also used for things such as lice and scabies. So again, you would never know what exactly the person had unless you were the person caring for the patient. So just follow the sign and that will protect you. Our next common sign is for our C. diff isolation, and it is called Contact Precautions D. It is brown, and it's for diarrhea. That's why there is a D there. The key with Contact Precautions D is it is also used for organisms that are spread by contact, but it is spread through fecal-oral route. So when I say that, what I mean to you is the environment gets contaminated from feces, you touch the contaminated areas, and you touch your mouth. That is the only way these things are transmitted. Gowns and gloves are again required for these rooms upon entering, but the big key difference with Contact Precautions D is that no Purell, hence that it is X'd out, can be used on the exit of these rooms. Because when the spores are on your hands from the diarrhea, you need to use the mechanical friction of the soap and water and the paper towel that's going to mechanically remove the spores. Because Purell does not kill C. diff or sporulated bacteria. So I'm going to talk a little bit more about that. C. difficile is the main organism that we use contact precautions D for, and it is a germ or bacteria that lives in your gut. When it produces the toxin, it can cause profuse fulminant diarrhea that is uncontrollable. It basically breaks down the pseudomembrane of your intestine, and it causes it to be uncontrollable and have abdominal cramping. So for this organism, the only thing that kills it is bleach. So as patients have these multiple stooling incidents in their room, they shed spores all over their environment. This organism forms a spore around itself when it's outside of the body. Envision it as sort of a protective shell. And the only way to break through that shell is with bleach cleaning. So for these patients, anybody that leaves the room or any equipment that leaves the room has to be cleaned with bleach. Anybody that leaves the room should have clean gowns, clean hands, and be continent with their stooling. And then the room is bleach cleaned as well. Droplet precautions, this is for our bacteria and viruses that are spread by large respiratory droplets. So when a patient coughs or sneezes, these organisms are very, very mucousy and large, and they fly out of the mouth and fall within about a 3-foot radius of the patient. So this would include things like flu, whooping cough, or also known as pertussis, or meningitis. For these patients, we require that you wear a mask when you're within that 3-foot radius of the patient, but I also like to stress standard precautions, so wearing gowns and gloves if you're within that 3-foot space, because remember, it's likely heavily contaminated with their mucus droplets. Airborne precautions is for our organisms that are actually spread on the air current. So what that means is a patient is infectious and they will cough, sing, or sneeze, and the organisms fly out and they're super, super tiny and they just float on the air current. And then you walk into that space and you breathe, and those organisms will fly down into your lungs. Okay, some key points with these with this precaution. It's the blue sign. The door must remain closed. And most essentially, this patient must be in a negative pressure room. Our negative pressure rooms are fitted with monitors next to them that show that the pressure is negative. And what that means is when the door is closed, air is constantly being pulled into the room, but what's in the room is never circulating out. So if you ever see this sign and you don't see a monitor, please, please notify someone that this is a concern, because they need to be in the appropriate room. Also with these rooms, the patient typically in our community is either being ruled out for tuberculosis or has tuberculosis. We have very, very, very little tuberculosis in our community, so that's good. But we rule a lot out. So that is what you would typically see. Another thing to remember is if you're a nurse, you will be fit tested and you will have an N95 to wear when you enter these rooms. If you are not fit tested, there will be a cart there with a PAP or hood that you will have to put on and activate when you go in that room. So let's talk a little bit more about tuberculosis. Tuberculosis is a disease caused by a bacteria called Mycobacterium tuberculosis. This is a type of acid-fast bacilli that spreads through the air, as I mentioned, when a person with TB coughs, sings, or speaks. The symptoms typically include coughing, hemoptysis, which is bloody sputum, weight loss, night sweats, fever. Those are the most common things. as we talked about, isolation must be airborne until the patient produces 3 sputum samples that are negative for this acid-fast bacilli. Until that time, they cannot come out. And the smears and cultures actually need to be finalized, not just pending negative. Another thing I like to point out with Mycobacterium tuberculosis is that there are types of TB that are called latent. So what that means is someone at some point was exposed to this organism, but they never actually developed an infection. It just lives in their lung, but they're not sick. They're not infectious with it, so it cannot be spread. So with latent TB, and we do have these types of patients, we do not have to put them in isolation because they're not actively spreading the infection. The person has to be coughing and producing sputum and symptoms to spread it. If a patient is confirmed with the AFB or the acid-fast bacilli testing and the smear is positive, we in infection prevention are always following up on these cases and working with employee health very closely. So please know that we get all of the positive cases and we will absolutely follow up if we feel that an exposure has occurred. Okay? And if you have, and then baseline testing will be done at the time of identification, and you will be followed up after that. If you did end up having a new positive skin test, you are not infectious unless you have active symptoms. So again, if you're exposed, we will work with you on whether or not you are infectious and can spread to other people. And until you have symptoms, you are not infectious. And then I included a link to our TB control plan in this presentation. If you want further information, you can contact Infection Prevention. I would like to go over our cleaning products quickly with you now. We have 2 main cleaning wipes here at UTMC that we use primarily. The purple wipes are our main cleaning wipe. So when you clean off your blood pressure cuffs, your IV poles, the beds, when you're transporting patients, we use the purple wipes in general. They have a 2-minute contact time, which means that the wipe has to remain wet on the surface and allowed to dry for it to kill all of the organisms. For our C. diff or diarrhea patients, we are phasing out these red dispatch bleach wipes and getting the Clorox bleach wipes. So you will start seeing Clorox bleach wipes in your areas. If not, they may already be there. And the contact time for this is 5 minutes. So again, if you ever have a C. diff patient or someone in your contact precautions D isolation, you'll need to clean everything with the bleach wipe. And also important to remember with these products is to always wear gloves when you're using them. A reminder, stay home if you are sick. There is a work restrictions grid and policy that Nancy will go over with you, especially if you ever have fever, rash, vomiting, or diarrhea. Those 4 symptoms are very indicative that you are infectious. Please, please stay home, or you will spread it to your other colleagues or even patients. And also stay up to date on your vaccines, and don't forget your flu shot. Lastly, I want to remind you as well to report all exposures. So if you yourself ever feel you've been exposed, please report to your supervisor. We typically go to the ED for initial treatment when there is an exposure that's happened, such as a needle stick or a blood splash. And then employee health and family medicine will follow up with you on exposure and treatment if it's needed. Infection prevention is everyone's business. Now I can be casual. So, sorry. I usually am much more interactive during that. We can cut right here, but I'm usually asking questions, getting you involved, but I kind of had to be, we're gonna, record this for the rest of the presentation, so we're gonna just play my voice. Sorry. So does anyone have any questions for me?
If a patient has a sensitivity to bleach or bleach products and then has C. difficile, how does that pan out.
Doesn't matter. Unfortunately, there's
You just
nothing
have to
else.
then manage their
Sometimes
reactions.
I think we've tried to make accommodations where we can get them out of their room while it's being used and get them walking. If it's really bad, we could try to move them to a different room. But typically now for our C. diff patients, they remain in precautions until they leave. So, because what we were finding is when we were taking them out when diarrhea was resolving, that doesn't mean the room's still not contaminated, right? So we take the sign down, okay, great, but people are still going in and out without gowns and gloves. So they're still spreading it. So we decided to just keep our patients in till they discharge and then clean the room. So I guess in that, if it was a really bad situation, we could hold off on the bleaching till they left and do a really thorough bleach clean. That's also an option. But there's nothing else right now that we can use. So, and the wipes are actually great. They're not as bad as when you make like your household bleach dilution solution and clean with that. That's much stronger, like with household bleach. The wipes are the same, but they just don't smell as bad. You can still smell the bleach, but it's not too bad. Yeah. Any other questions at all? So can we go around? Where will you be going or working? Sorry.
I'm a lab tech. I think mostly I'll be in the ER third shift doing drawing blood. So.
Oh, wonderful. Okay. Well, make sure when you go down there that you get education. We are currently working very closely with the ER on how to draw blood specimens correctly without contaminating. We're getting a lot of skin contam blood cultures, and what that's doing is it's causing physicians to treat when there's not an infection going on. So now we have overuse of antibiotics, right? Antibiotic resistant organisms start happening that way, and we're finding that it's a technique. So we're working very closely with ER on all that.
Scratching the skin when they go.
I don't think that they're scrubbing the hubs of a lot of the lines as much as they should, and how are they flushing, and all of those pieces. I'm not working on it, but I know my boss is pretty closely, so I should ask about it.
Definitely will.
Perfect. Hi.
I'll be an inpatient pharmacy.
So you will be going in all of these rooms, and so
I'll be working orthopedics.
in the clinic. Okay, great. Are you? I'm sorry. What is your role on? Medical assistant. Okay, fantastic.
I'm an MA. I'll be floating to most of the clinics here.
All the clinics. Okay, cool.
I'll be a dental assistant in dentistry.
Scribe in family medicine.
Scribe. Oh, that's the first time we've had a scribe in here. Very cool. So I actually cover, usually I go over that to what each of us covers, but I thought, well, if any of us ever leave, then we'll have to redo it. So I didn't say what each of our roles are, but I cover all the clinics, so I will see both of you a lot, all three of you actually. I cover everything cancer, so Dana, Kobeck, or Psych is all mine. 4th floor, 6th floor, ortho, detox, that's me. So I'm like the clinic cancer psych person. So, but I'm everywhere. And I also cover high level disinfection here at the hospital, so I have to make sure everyone's doing what they're supposed to with that, which is a whole nother issue. Did the whole concept of cleaning your hands before putting on gloves make sense to everybody? So it's not intuitive to people to do that, so I always like to hit that pretty hard. And then I newly this time added more information on tuberculosis because we're required to educate all of you on higher, and I don't think I was doing that adequately. So do you have any questions about that at all?
Do they have a preference for us washing hands outside of the patient's room before we enter, or doing it in front of the patient once we enter their room so that they have the security of mind going, okay, this person actually did wash their hands?
I always say either for me works. We are auditing you though all the time. It's a Joint Commission requirement that we audit our hand hygiene, so all of you, I hate to say it this way, but you're being watched by lots of people. And we have to return in observations and look at the data over time and try and increase our compliance. So the only thing is, and people are being trained to, if they don't see you do anything, not to record it, but the only thing I could see with that is if you waited till you were all the way in and by the bed, they shouldn't be marking that as non-compliant, but I think that we are slowly moving into a culture of let your patients see you.
Absolutely. I think it's very
So I think
important
it's very important.
for patients to see you washing in and washing out.
But you could do
It's
both.
very reassuring to them.
It is. You could do both components, right? So you could, as you're putting it on, you could walk in and talk, hi, good morning. And so then you're accomplishing both at the same time. It's kind of my recommendation.
Okay.
But I agree with Nancy that I really like the patient seeing you do it. Even if you're not touching anything, you have to clean your hands. Shoot, I didn't say that.